everybody. Welcome to the Healthcare AI Hands-on Machine Learning broadcast. I'm Levi Thatcher. This is Mike Levy.
Hello, world.
Happy to have you here. Mike's joining us, Health Catalyst. This is your second week, kind of first quasi-normal week, Health Catalyst. And we're thrilled to have him joining us on the broadcast, on the team. And please reach out, ask him advice in the Slack channel at the Healthcare AI Slack team. He's around to help, and I've been taking full advantage of his help. Where do you come from? Mind giving just a little bit about background?
Sure. I just finished my PhD at the University of California, Davis, doing data science-y kind of stuff in social science. A lot of network analysis, a lot of statistical modeling, and a lot of teaching R and machine learning.
Social science time with data science. I love it. Is that a department-wide thing, or was something more that you personally took on?
It was more my push.
Yeah. That's awesome. I think we're seeing more and more of that across social sciences. Maybe a little less than the hard sciences, but...
Yeah, but people who are drawn to these tools see how much can be done.
Yeah.
Go out and pick those skills up and bring it in.
Yeah, that's fantastic. Okay. Thrilled to have you with us.
Thanks, Levi.
Just in terms of logistics, we'd like to have you log in to the YouTube app or website so that you can participate in the chat. We always love feedback and want to make sure that we're interacting with you. That's the whole point of this. And there you can also adjust your resolution. And we'd like to encourage you to subscribe to the Healthcare AI Slack channel. You can do that on the healthcare.ai website. That way, after the broadcast is over, we can interact with you during the week. You can ask us, we can learn from you, and have a more full discussion and learning session between us. And on the Healthcare AI site, you can subscribe to the community as well. So get the blog posts that come out. We're trying to keep those at once a week. So, we haven't mentioned this lately, but we'd love to invite you to Salt Lake City in September. Lovely time to be in town. For those of you who haven't been to Salt Lake in September, we're going to be doing a 2-day hands-on R training that Mike will be doing. Thrilled to have you help with this. For both analysis and machine learning in R. So for those of you who want more of a personal interaction with us and want to really dig in and have a sustained training, come to Salt Lake, look at the website. It's Healthcare Analytics Summit in Salt Lake in September. Again, we're having a 2-day training before that summit kicks off. Check it out. And to start the broadcast, we're first going to be doing a little bit of a technical session here, and then we'll move on to an interview with Ben Cleveland from Unity Point Health System. We're thrilled to have him with us. And first off, let's talk a little bit about Healthcare AI, the software. Sometimes we forget that there's actually code here that we're dealing with and using. So a lot of times you set up a model, you put it into production, and then you want to check, okay, well, is my production accuracy holding up as well as it did when I was just using retrospective data? And so we built Healthcare AI to help with all those sorts of questions. And if we jump to my screen here and focus in for a moment, do some hands-on coding, what you'll see here is RStudio. And we've talked a little bit about this in the past, but the idea with RStudio is that it lets you interact with R in a coherent way. And it's actually a fantastic tool. And I would encourage you, if you're working in R, RStudio is a fantastic way to go. What we see here is you have a console window on the bottom left where you can interact with the tool. So what I've done is loaded in Healthcare AI. I want to pull up the library and actually look at the documentation. And if you do this on your machine, what you'll see in this Help tab here is a general background on Healthcare AI itself, what you can do with it. And if you scroll to the bottom, what we'll do today, maybe we should make this a little more prominent, is we want to play with this generate AUC function. So let's say you want to check in and see, okay, well, how accurate is my model? What I have here is one column that I've predicted of probabilities and one column of truth. So let's say that we're predicting readmissions, and we want to say, okay, well, we've generated 100 predictions, and the predictions are probabilities. We want to compare these and see, okay, well, how did this compare with the actual truth of people coming back to the hospital or not? And so let's load in, using our select data query here, let's load in a data frame, and this is a pretty common operation in R. And so what you can see there is we've loaded in the yes, no flag of our truth, and then the probabilities that come out of Healthcare AI. And this is a common scenario, so generally when you're dealing with models, you'll have the truth that maybe you have to wait a few weeks or months to gather the truth of people coming back to your health system or not. You'll eventually have it. And then you have this predicted probability as to what the model thought would happen. And so if we want to look at the documentation for generate AUC, you see all the different arguments. You see some examples down below. And so if we copy this over after we loaded in our data, what you do is you simply, let's pretend that we were just doing this fresh here, and we'll ride the lightning a little bit. So if we copy this over from the help screen, what you'll simply do is you have the data frame, and so you want to say, okay, well, my predictions are this column, my labels are that column. Labels is the truth in machine learning parlance. And if we go ahead and run this thing, we'll get quite a bit of output and a plot as well. And so rock plot is a great way to evaluate how a model is done. You see that right here. And if you look in the output window, what we'll find, quite a bit of output, but the main thing we want to focus on is the area under the curve of this rock plot is 0.98, which is pretty fantastic. And this is just dummy data, so that doesn't really mean a lot. But the gist of it is that this generate AUC function lets you evaluate model performance in production. Or wherever you are, if you have a prediction and the truth column, you can quickly get an estimate as to how accurate that model was in generating that prediction. And along with that, it comes with the true positive rate and false positive rate cutoffs. And you can go ahead and play with that output when you get it. But that's super handy when you're considering, okay, well, do I want to err on the side of more false positives or false negatives? This gives you an idea as to how to make that decision. And this will actually be a great place to bring in Ben Cleveland. Like I mentioned, Ben Cleveland is joining us from Unity Point Health System. How you doing, Ben? Can you hear us okay?
Hey, doing well. Can you guys hear me okay?
Yeah, you sound fantastic. So Ben, we're thrilled to have you join us. Thanks for taking the time. And we wanted to just learn a little bit about yourself and a little bit about the health system you're at Unity Point. So talk a little bit about how you got to where you are.
Yeah. So I actually grew up in healthcare my whole life. My dad's a physician. I spent my summers in the back closet making paper charts. So I've been around healthcare and all its nuances for a while. I really enjoy using math and other technical methods to solve problems in operations. So I did my undergrad in statistics and operations research, and then got a master's degree tailored towards kind of applying that to healthcare problems and health systems. So after that, I launched into kind of an industrial engineering type flavor of work for a little bit, and then analytics kind of took off in healthcare, so I jumped ship and eventually came into a data science role, which I've been doing for several years now.
That's fantastic. Yeah, kind of like a lot of the data science folks, a varied background here, kind of a meandering path. I can relate to that for sure. So master's was in Georgia, correct?
Yeah, I was at Georgia Tech. They've got a health systems engineering program down there. So tons of connections with local hospitals and practitioners in Atlanta and everything. So it was a really great opportunity for me. One of a kind at the time, but I think other schools have started to offer similar programs incorporating data science too, which is neat to see.
Yeah, that's fantastic. I've heard that they have quite a good data, master's in analytics at Georgia Institute of Technology that's kind of popped up in the last couple of years with an online option as well.
Yeah.
So, yeah, for those folks out there looking to get those sort of the formal classroom training, I hear that's a great option. And then North Carolina for your bachelor's, right?
Yep. I'm a Tar Heel, so still enjoying our championship victory this spring.
Beautiful. Yeah. Insert random sport banter here. I don't know if you follow basketball. Oh man, we're gonna work on that a little bit, Mike. 2018 resolution. I hear Georgia has amazing. I was actually in Atlanta one time. Amazing barbecue. So if you have any restaurant recommendations, maybe we can take those in the Slack channel after the broadcast.
We can't do barbecue banter?
No, I can banter about barbecue, definitely. If you want to take a second. Collard greens, I hear that, very southern focused.
Oh, yeah.
You can't really get those much in Utah, so sorry, I don't know if you have a...
Oh, man.
I don't, sorry, I should have told you that in the interviews. But anyhow, we should probably talk about healthcare a little bit. So you're at Unity Point, big health system in Iowa. Here's the biggest health system, would you say, in Iowa? Patient visits?
Yeah, definitely the biggest in Iowa. 13th largest health system in the U.S. So we're not just in Iowa, also in Illinois and Wisconsin. So we've got a pretty big footprint here at Unity Point.
That's awesome. So expanding over into Wisconsin and Illinois, and
Mhm.
tell us a little bit about the analytics development there. So typically, it seems like the route goes that you have analysts, you have a data warehouse. It's kind of the first foray that most health systems have, and then the data science kind of comes after that. Does that jive with what happened at Unity Point, or do you mind just talking a little bit about the progression there that you saw?
Yeah. So I guess it's been about 4 years now. We there was a big initiative from the top executives to create a centralized analytics function. Um, so we had analysts in different pockets of the organization who were basically consolidated into this one department. I came on just after that. And so we kind of do the whole gamut here. Within analytics, we've got your reporting, dashboarding, traditional BI stuff, historical data analysis. And then once we moved into more of a pop health environment and trying to address those problems, we really saw a need for predictive analytics, a lot of use cases where predictive modeling just made a lot of sense, finding patients who would be at risk for incurring a lot of healthcare costs in the next year or so. So that was our first foray into there. We had a decent amount of success with it. We were able to deploy some models that were actively used by care teams across our system, and then it just kind of evolved and snowballed from there as we found other predictive modeling use cases and kind of expanded our scope. So certainly an evolution from traditional BI type work, and we still have all those functions, but we're moving into more of the advanced type stuff now too.
That's fantastic. Sounds pretty familiar to the interactions we've had with other health systems. That's great that you guys made it to that point where you're able to use data science. A big question people have is, how do you determine the lowest hanging fruit? So data science is sexy, the tools are pretty easy to use, hopefully healthcare AI has kind of helped with that. But
Yeah.
when the rubber meets the road, people struggle with, okay, well, where do I actually start? How do you balance the competing interests for, precious time and resources?
Right. Yeah, it's definitely a tough one. I'd say for us, it's been a combination of where are people using data tools to make predictions, even if they don't really think they're doing that, in the course of patient care, and then what are the biggest problem areas that our system is focusing on. So, just like a lot of folks in the industry, readmissions is a good example for us. They are using what's called the LACE score. It's basically a simple algebraic model where people would add up a few points based on four variables, and a risk score would be outputted, and then they would go focus on those patients that were high risk. So that was already embedded within their workflow processes. They weren't really happy with the output or its accuracy, and once we realized that, we figured we could come in and behind the scenes really augment that decision point where they're trying to figure out the risk of a patient, with a lot more advanced predictive modeling. So it was still a challenge, but as far as low-hanging fruit, I think that was probably the best place for us to start in care planning, clinical applications of data science.
That's fantastic. So Mike's newer to healthcare than some of us, and so with the LACE model, that's generally where you insert your boos and hisses as a data scientist. Ben, is that right? So for those that are uninitiated with LACE, the idea, and it was a cool paper. The idea is that it's a heuristic model, you could call it, I guess, where you have coefficients that came from this paper, I believe from a cohort in Ontario that was studied in the 2000s, and. Yep. This is how it works a lot in healthcare. You have these coefficients from a paper that get implemented, and then people drive decisions off of those. But so what made people realize that LACE wasn't working sufficiently well?
I think it was a combination of just pretty severe misses by LACE. So, for example, maybe LACE would give us a score that's super high to someone, and they're obviously totally able to take care of themselves. The opposite end of the spectrum, very high risk patients that are obvious to clinicians looking at them, but LACE would give them a low score. So really just kind of a miscalibration led to kind of a lack of faith in it. I think they also, as they were using it, didn't see a ton of improvement in outcomes and readmission reduction strategies and that sort of thing. So they couldn't really see its usefulness in the real world, and that gave us an opportunity to jump in.
Yeah, wasn't super accurate. Something that we hear quite a lot. So for folks that are unaware, that's where I usually start when explaining machine learning to folks in healthcare, how it can help. And with LACE, correct me if I'm wrong, the idea is that it's focused on a population that's not yours in a decade that's not this decade. And so machine learning can say, okay, well, we're going to treat your population as being different than all the others, than the Ontario population, and we're going to say, let's focus on the relationships between patient attributes and readmissions over the last couple of years instead of from 2007 or whenever it was. But that's kind of a place where I start. I don't know if that was helpful for folks in your organization to kind of see that difference. Was that the kind of the first project you worked on, was LACE at Unity Point?
Somewhat, yeah. We tackled a few concurrently, so we worked on length of stay and readmissions. But yeah, I would definitely agree with you, Levi, that when you say that we're going to create these models based on your own unique patient population, in the last couple of years, we've found that really clicks with folks too.
That's awesome. Yeah, I found the same. So the timing thing is big for me too. So with LACE, it's only available at a certain time because you have to have the 5 or 4 variables to make the calculation. And it's only possible at patient discharge, if I understand it right, since length of stay is one of the input parameters. And so with machine learning, you can make the prediction a lot earlier during the inpatient stay, since it's based on whatever data is available when the clinicians need the prediction. So did you guys actually do a prediction or guidance during the inpatient stay, or was it more at discharge?
Yeah, I would say the primary application for it is in discharge planning, but once the patient hits our doors the next day, we're already pulling data on them, sending it through the models and getting that information to the clinician. So we've got tools where it grabs all of their data that they've generated the inpatient stay, generates a risk score for readmissions, estimated length of stay, that sorts of thing. And as the intensity of their care increases, the models will pick up on that increase and adjust those outputs accordingly. So yeah, we're running the engine the whole time that they're in our hospitals.
That's fantastic, and it seems like a prime opportunity to make resource allocation more efficient during the inpatient stay. Clinicians now can see who needs more attention with a high degree of accuracy, and that's kind of amazing to me that is so new to healthcare. So let's talk a little bit about creating models, putting them into production. So a lot of health systems struggle with that piece, and a lot of data scientists in healthcare struggle with that. So you'll see a lot of academic studies where folks talk about an accurate model they created, and it's fantastic, and here are the variables we used. But if you follow up and dig deeper, you never hear about it being in production and helping patients day to day. So how did that work out for you guys? Do you have any advice on how to actually get a model into production after you've trained it and found it to be accurate on past data?
Yeah, it's people don't believe it, but that is the hardest part of healthcare data science by far. So just a few challenges that we've had, and in some ways we've overcome those or circumvented them. The first is you have to set up the pipelines to do that continuous scoring. That isn't always the easiest with electronic medical records because they have their own proprietary software. So you're really constrained to what you're working with from electronic medical record standpoint. You have to decide if you're going to put the score or push it back into the electronic health record, which is part of the native workflow of the clinician. So it makes it more likely that they'll be able to adopt that score and use that information, in the course of their workday, versus them having to go outside of that application and click through some things and find it elsewhere. But typically what we found is if you want to do that push, it's very resource intensive. So you have to kind of balance the cost benefit analysis of doing that. versus you can do the scoring externally from your electronic medical record, stored in probably your electronic data warehouse, and then build some external tools on top of it, like if you're using Tableau dashboards, for example. So what we've found, just to get the ball rolling, we've stuck with the external route. So we built all those pipelines outside. We'll extract the data. There's about a day lag that we have to work with, but other than that, we maintain control over the whole pipeline, and then the output is stored in our dashboards that care teams can go out to. But so we're working on trying to make it a little bit easier to get back into the electronic medical record.
That's a great point. That's an important topic. I think that's a little bit under discussed in healthcare data science, is that you have sort of these two different ways to visualize the data for clinicians within the EMR or with BI tools, and that's kind of a stark difference, leads you down really different technical pathways. And Ben mentioned the term scoring. I don't know if a lot of people know, but basically giving a risk score to a patient is what we mean when we say scoring a person. And with EMR integration, people often call it closed loop. Is that the term you guys use? Is that
yeah, I think that'd be accurate.
Okay, yep. So closed loop is obviously the more difficult of the two, because you have to deal with build queues. Ben, maybe you could speak a little bit to that. Have you guys, with EMR integrations, or at least the attempts thus far, is the build queues been what slowed you down, or what is it?
Yeah, so all the resources that we would need to build the pipelines within Epic as our EMR, those exist outside of analytics. So we would have to compete with the rest of the enterprise as far as their priorities, as far as getting resources to push that information in there, which is a very tough thing to do for us. So that's why we elected to stay external for now, but it's definitely a challenge we're trying to overcome.
Yeah, okay, that sounds familiar. So is that more of, would you say, a financial cost, or it's just logistical difficulties of getting a risk score shown in the EMR?
I would say probably both. We're kind of at a crossroads as far as what is our data science strategy. Are there certain use cases where we're going to definitely always stick with incorporating these into the EMR? Should we use out-of-the-box EMR models that they've created the last couple of years? Should we keep it external and maintain that governance over that process? But so there's financial cost to a lot of those routes. Also, a lot of logistical problems, just taking our place in line as far as projects and securing resources too.
Yeah, only so much real estate on those EMR screens, perhaps part of it. Competing interest there. Very fascinating. So I think that's kind of a sticking point, I would say, for a lot of the production issues that people find, is that you have your EMR vendor who maybe has a competing interest, maybe we could say, where they have data science projects and they obviously want to show their data science capabilities. And then these health systems, not just Unity Point, will have data scientists that are doing work on the ground. They're sort of the boots on the scene on the ground. They're creating the models from the ground up and obviously want to have their work shown to clinicians. Has that been sort of aired at a high level at Unity Point, or what's the status, or what are your thoughts?
Yeah, certainly there's a component on the EMR side. Obviously, they're creating these capabilities, and these are revenue drivers, so they can license those models out. And I think, I don't know, there's not a huge incentive for EMR companies, I think, to make external data science easier, because they can kind of have a hold on that market, given that you're forced to use their product. But for us, it's do we build this up within our EMR? Is there data outside of our EMR that we want to incorporate into our models? How can we utilize that effectively, given the constraints that we have? So I would definitely say there's a little bit of that there, just kind of market incentives for developing capabilities and whatnot. So it's definitely something we have to navigate.
Yeah, I think a lot of health systems can relate. That's fascinating. So we wanted to talk a little bit about model maintenance and telemetry, you could say. So telemetry is gathering data about some process. So you have these models in production that are feeding Tableau dashboards. Do you have any advice, or how do you guys approach the problem of, okay, well, the model was good on day one, was accurate, but how do we know when the accuracy deteriorates? How do we check in? Is it manual, automatic? How do you guys approach that problem?
Yeah, so this is really tough for me. I'm actually all ears because really, if you step back and think about it, you want your model's accuracy to get worse over time, especially if it's like a readmissions type thing. You know, if we're taking action based on our model's output and that action is effective, we shouldn't see repeat readmissions in the future. So people that my model flagged as a high readmission risk but ended up not readmitting, we hope that's because of the action that we took. So really, performance metrics after that deployment are really tough because you're not dealing with a controlled environment. You know, this action versus that action was taken, that sort of thing. So it's really tough to get kind of an unbiased estimator of your model performance post deployment. So I'm kind of at the junction where maybe we should just set up automated procedures to recalibrate the model on a regular basis. So I'm thinking about incorporating maybe quarterly. We'll set up automated processes to just retrain the model, refine and retune any coefficients or that sort of thing, just to make sure the model is staying up to date on the behavior of the health system, if that makes sense.
That's fantastic points there. So if your model's working well enough, you sort of ruin your future training data, as it were, if you're keeping people from coming back to the health system. Have you guys used control groups at all? I mean, what's one thing that's come up in our endeavors is, number one, if you want to evaluate the efficacy of your clinical guidance,
Mhm.
you know, it'd be nice to know what would happen if that guidance weren't there, and control groups have seen a natural way to evaluate that.
Yeah, I hear you, and that's something I bring up pretty often. Is if we want as precise as sound of an evaluation of the effectiveness of this, we really do need control groups. It's also difficult because usually when you're deploying a predictive model into some sort of strategy to improve outcomes, there's usually more than a dozen other items within that strategy that they're also pursuing simultaneously. So um, control groups in the strictest sense really haven't been too practical for us. It's a hard sell to say, you know, take this unit and do all this stuff and leave that unit alone versus kind of just here's our strategy. Let's try to get everyone up and on board and running on this. Um, so yeah, it's really a problem that I struggle to know how to address. It would be nice, I think, if more academic settings where that sort of environment was more commonplace and encouraged, they would pursue those sorts of control groups and interventions and that sort of thing. But we're not an academic health system, so we're typically don't pursue control groups, unfortunately.
It's difficult. A lot of logistical challenges, like you mentioned. So you have all these other interventions going on, and so you have to determine maybe two departments or hospitals that look very, very similar in terms of demographics and other factors, and then say, okay, well, this one hospital gets our predictive guidance and the other one doesn't, and then for how long do you do
Right.
it? A lot of things to sort out there. So, yeah, we would love anybody in the Slack channel or in the chat there, if they have any advice on how they've done that in their health system.
Yeah.
So,
And further
go ahead.
for us, we since we're in a few states and our hospitals really span the range from very rural to very urban, so the behavior and population makeup, the staffing resources are just extremely variable across our health system. So yeah, I'd be all ears for figuring out how we can get a better handle on effectiveness. That'd be great.
Yeah, that'd be actually a fantastic topic for another day entirely. Just how do you justify the work that data science entails? How do you justify your existence and say, okay, well, machine learning did this for our health system.
Right.
Because it seems so difficult, like we said, to suss it out from the analytic initiatives in general.
Mm-hmm.
Awesome. So in terms of this telemetry, so you mentioned quarterly retrainings. That's something that we thought about as well. And one thing I was wondering, with the retrainings and with the initial trainings of the model, how do you guys work with subject matter experts to get advice as to new features or ideas on what to pull from the EMR?
Mm-hmm. Yeah, so most of that will occur during the initial development of the model. We'll do a lit survey, see what the research has shown, what features are other people using. Those are usually not a huge surprise. We're all kind of doing the same thing with the same data. But really where the money comes from is when you sit down with physicians and other clinicians that are kind of boots on the ground, and they just know, or they can sense different variables that could be very valuable to you. So I try to have as many interviews as I can with folks. Their time is very valuable and they're hard to get on the calendar, but I try to sit down with them, say, we're trying to predict readmissions. What have you seen in your patient population that would cue you into this patient is more high risk, or whatever outcome we're working on. So they'll kind of lay those out for me, and then I'll follow up with an informaticist actually to figure out where that would be stored in our EMR, how we would pull it, what that data would look like, and that sort of thing.
That's nice to have those cross-company connections there. As we've said in other broadcasts, it seemed pretty crucial to a successful endeavor.
So, Ben, one of the questions that's come in over the live chat on YouTube is which features you found most important for the readmissions model. Would you mind sharing some of those specifics?
Yeah. So I would say for our readmissions, we found that just kind of variables that speak to general morbidity burden have been our most valuable. So what I pulled into the readmissions model was I think I've got like 16 variables, counted medications administered by therapeutic class, several lab values indicating severity, so arterial blood gas, different, what are they called? Sodium, potassium, just general lab tests that are ordered a lot. We've worked in procedures into our readmissions model. So surprisingly, a lot of people are really into socioeconomic data right now, and it makes a lot of sense from kind of an intuition standpoint. But we haven't found that that data is heavily populated in our EMR. We've tried census data. It actually trying to speak to a patient's socioeconomic status, like income levels, education levels, trying to get at if they're far away from a hospital or poor access to care. And unfortunately, the census data hasn't worked out too well for us. So far, just a lot of variables that indicate overall morbidity burden combined with things like age and sex and financial status and that sort of thing.
That's super helpful. Thanks for going into that. We actually found the same in our initial attempts with census data, and it might depend on the grain. I can't remember if we talked about this, but remember if you're at the zip code grain, or how deep did you guys go?
Yeah. The census, it's been a while. They have kind of a zip code equivalent grain, and it felt like it would be useful, but ended up not having any effect. I also tried taking the patient's home address and calculating their driving distance to the nearest hospital or nearest healthcare facility. And interestingly enough, that actually had no effect either. So we're still searching for those golden features. But
those geographic features could be broadcast in itself. There are a lot of logistical hurdles as to how do you actually make that calculation, without having to call out to the internet, at the time of making a risk score for a person. We'll have to defer it, sadly. But it's awesome that you actually got the model into production and had an impact on patient care. What was the clinician reaction? You mentioned having these these subject matter partners that have helped in finding features. What's been the reception with them in terms of machine learning and having this clinical decision support?
Yeah, I think it's definitely runs the spectrum, right? So you have physicians who are totally on board, totally psyched about it. They're just ready to jump in full force. You've got most of your physicians who are pretty much like, I'm too busy for this, go away. And then you've got, on the other end, people who are kind of hostile towards it because they feel threatened in some way by it. So I would say that is probably descriptive of how it works here. We try to focus on partnering with, obviously, the people who are super excited. But we found, the best way to move that middle tier, the ones who just kind of have a passive interest or not really in it at all, but no hostility towards it necessarily. To get them excited, it's really important to recruit their peer groups, so get physicians on board, but also if you can demonstrably show that, when this machine learning algorithm was incorporated into a strategy, we saw positive outcomes for the patient. And then that'll kind of get people's ears perked up because physicians in general are very evidence-based. They want to see the numbers. They want to see results. So yeah, that's how we've kind of experienced
Leverage your success. That makes total sense. Would you have any advice for folks out there that are analysts or data scientists trying to get clinicians involved and they haven't yet had a success story at their health system around machine learning? Well, I guess what's your pitch to clinicians when you talk with them?
Yeah, let's see. I'm not pitching a lot in my role, but I would certainly zero in on clinicians that do have that interest, and then see what they like to work on. See if you can come up with a project that would really get them excited, and then develop it out. Even if it's not maybe a high impact, something like readmissions, find something that folks are excited about. They'll get on board with it. You can show results and then use that success and kind of snowball into more of the quote high impact projects, if you will.
That's fantastic. Just basically get started, start building a model. Related to that, I found that clinicians get super excited when you're showing them how the model improves with new features that they found. It really gets them excited to find more features and to dig in the literature and think about the EMR and what's being recorded. So just getting practical, hands-on experience for them, I think, gets a lot of people involved and excited to pursue it further. Any last advice? We're about 1:40 here. Do we have more questions?
Yeah. Jonathan asked, what software tools are used at Unity Point, and are analytics run locally or in a public cloud provider?
We're not in a cloud. Yeah, we're trying to figure out the security issues involving HIPAA and what all of those issues would entail. So we're not quite in the cloud yet. I'm not sure if it's on our architectural stack roadmap, but I think we're looking into it actively right now. As far as the rest of the software, so we do all our development in R. Models are created in R, and then actually we have an instance of R installed on our EDW server. So our production jobs will call R. Within that process, score the data, and then within R, they'll push it back to our databases. So Microsoft SQL Server Stack plus ours is probably our main development tools, and then Tableau for visualization.
Sounds like a pretty awesome setup there, and one that I guess a lot of people could emulate. So, and cloud seems difficult in general because the HIPAA issues you mentioned, but for folks that aren't in the cloud, you don't necessarily have to worry. Healthcare AI is meant to be installed where your data lives, so it's perfect for regular database servers that you may have. But then, like Ben mentioned, Tableau, SQL Server, R, Healthcare AI, you can get started pretty quickly with those simple tools, and a lot of them are free. I guess SQL Server is probably in your health system already, or Oracle in general, but fantastic advice, Ben. Anything else before we go? We have just a minute or two left. Any other questions?
Yeah, we have one more if we want to take that. Clinician idea for machine learning on utilization management. Any input?
Ooh, Utilization management. It's a hot topic here. So the folks that were hostile towards machine learning, utilization management is a tough subject to broach, I guess. So I don't have any great ideas for you right now. We're actively working on it, trying to figure out who our champions are in that space and how we can get some traction there.
Is that this basically where we're telling clinicians you guys order too many tests? Or utilization management, is that what that means?
Yeah, I will. So I will give you an idea. I did some work with a physician a couple of years ago in blood management, so utilization of blood products. What we basically did was we fit a model to calculate a patient's probability of getting transfused based on their hemoglobin values that they've had in their inpatient stay. And then we used that model to assess transfusion decisions throughout the health system. So it allowed us to kind of sit down with providers and say, here's clinical guidelines on transfusion medicine, how that's changed over time, moving towards a more restrictive transfusion practice. Most of your peers are transfusing down in this range of, 7-ish, around there. You're still up in the 9s. Let's talk about, why you made this decision, what types of evidence, you saw that you could lead you to believe that was a good idea. And let's try to get you down into a range that our clinical guidelines are showing. So we had some success there. It is a difficult area to preach, though, for sure.
Yeah, that's a very unique case. We'd love if you're willing to hop in the Slack channel afterwards and in the coming week, as people have questions about these specific use cases. A couple of them seem pretty innovative and haven't really heard too much about them before. So we'd love if you can help out with people's questions afterwards. But
yeah, absolutely.
We covered the main points there in the chat.
Yeah, I think so.
Ben, we'd love to have you on again sometime. You're doing fantastic
Awesome.
work there at Unity Point. We'd love to work together here. Maybe get your help in
Yeah.
improving healthcare AI software one of these days.
Sure. That'd be great. Yep, I'd love to.
Yeah, we'll do some pull requests. But thanks for coming on. We appreciate your time, and we'll talk soon. And
bet.
for those of you who joined, thanks for joining us. We encourage you to join us on Slack, healthcare.ai/Slack. And come join us in Salt Lake City in September for the 2-day training for R analysis and machine learning. You can find out more if you Google Healthcare Analytics Summit. Thanks for joining us. We'll see you in 2 weeks on July 13th. Thank you for joining us today. Remember to like, share, and subscribe, comment below, and click the links below to join our Slack channel and our Healthcare AI community.